Good afternoon, everyone, and welcome. I'm Zhang, Dean of the McWilliams School of Biomedical Informatics at UT Health Houston. As you know, we are gathered here for our 8th annual celebration of the Zhang P. Glaser Health Informatics Society. Many of you in this audience are well versed in our school's activities. However, for those of you who do not know us, McWilliams School of Biomedical Informatics, or MSBMI, as we are now called, is part of UT Health Houston, a comprehensive health science university. We work together with our sister schools, the McGovern Medical School, Civic School of Nursing, the School of Public Health, School of Dentistry, and the MD Anderson UT Health joined Graduate School of Biomedical Informatics, and the most recent addition, the 7th School of Behavioral Health Sciences, the first one in the nation. I want to start with just a few slides to give you an overview about our school. And you will see a lot of growth of our school, and people always ask me how to do that. What is the main driver? I always tell people, we do things for fun, for entertainment. So let me start with my first thing. Okay, I want to play with some video here. That's part of my job, and actually I do this in my office hour, so official time for entertainment. Okay.
In a universe where data is the new oxygen, every byte is a breath of life. Our doctors aren't just caregivers. They're navigating the frontiers of human health.
I'm not a doctor. Don't come to me for any medical problem, but... Okay, one more.
So, you think you're ready to teach here?
Affirmative. I already graded myself, A+.
Just remember, empathy counts too.
Uploading empathy, 83%.
Okay, it took me about 5 minutes each to create each of the video. It's all done by AI, by OpenAI Sora. And there's still a lot of things you can do to improve, but you can see that the quality is actually pretty good to my standard. So that's what we do for fun, and that's what drives us, has been driving us for the past 27 years. And we change ourselves and do new things and play and have fun, all right? Okay, let's just give you an overview about some data. We're all data-driven people. Our school is still the only freestanding school in biomedical informatics in the nation and probably in the world. And we are still the largest, I think, in terms of student body and faculty size, unless someone tells me, no, you are not. But I'm still make this claim. We have a total of more than 800 people, including 151 faculty members. 68 of them are the regular faculty members, but that I mean that they're paid by the school. Most of them are full-time. We also have more than 80, I think close to 90 adjunct faculty members. Some of you here are our adjunct faculty members who contributed to our research, education, service, and everything in different roles. We have more than 150 staff members, including more than 100 research staff and admin staff. And we also have GRS, TS who are working as part of the activity for the school. We have 3 departments which were established 2 years ago because we grew so fast, too big. And because I became lazy, I said I cannot do this anymore. I gave it over to 3 department chairs. So I can spend more time to create AI videos. Our academic program is pretty comprehensive. It covers pretty much the entire spectrum of graduate education. We have 2 doctorate degrees. The PhD is something we all know, and the DHR is something very unique. It is the doctorate in health informatics, the nation's first, and it is a practice-based program. And many of the people here are part of the DHR program. I think many of you have talked with them, and I think you would be impressed by what they do, where they're from, and what they want to do. We also have quite a few joint programs like MDMS, MDF, PharmD, and a large master's program that has over 50% of our student population. We also have the Clinical Informatics Fellowship, which is based in medical school and jointly run by us, which is for physicians who finish their residency, who want to get into informatics training, and for future career. We do a lot of research, of course. Last year, our research expenditure is close to 30 million. And we have 7 research centers. 5 of them are on AI. Not surprising at all because everybody's doing that. We also develop actual products, AI products. That some of these are used by our practice and at a scale and every day. One of them has been used by more than 1,000 users and processing more than 1 million documents per year. So we do everything here. Okay, so here's my favorite slide. And every year I add one more bar over there to show the growth, the history of our school. I always try to compare with all the major names you are fully aware. And the reason that I believe our school has been a startup and is always a startup, which we reinvent ourselves every 5 years or so, change to different things. So the first one on top left is our student enrollment. And I use Apple stock price and to do this. The correlation is not too bad, 0.86. The one on the right side on the top is our research expenditure. So this is the one I created last year. One Judy Faulkner was the awardee. She founded Epic, and the CEO of Epic, I showed this to her. She said, "Okay, well, we are sisters and brothers. We have long way to go together." And for the faculty size, I don't want to compare because we're still waiting for the big boom for the next few years before I will get a company name here to do the comparison. And our endowment, the gift from our community leaders, that grows substantially. So I picked NVIDIA, the most valuable company now in the world, I guess. You can see that correlation is really good. So that's our history here, and I hope this trend will continue. I do believe that we will go upward and hopefully go faster than NVIDIA. And all right. Okay, so as you can see there, most of the growth were over the last 10 to 15 years. And it's not by accident. And here is one of the charts we created that shows the growth of AI. So this shows the relative frequency of the keywords like AI, data science in the entire Google universe. And it's normalized, so that's the real growth over there. You can see the trend over there, which is actually highly correlated with what we have for our school. If you look at it even bigger, like across the entire human history, you have the Industrial Revolution and other things. So here's the chart I created. The left one is I estimated. The right one is on the data from myself. So if you go from Houston to New York City, if you walk, it will take you 3 months. If you bike, 3 weeks. If you drive 3 days, if you fly, it's about 3 hours. So that's a dramatic reduction of physical labor and cost by 98% with my calculation. I did one on the right because I tried to come up with one that is driven by AI. So I did a search of all the AI courses in healthcare for credit across all the 156 AMC institutions in US. I tried to do that by hand. It took me about 30 to 40 minutes because I have to go to the course catalog, look courses one by one. It's really time consuming. I want to use Google and reduce it a bit more, about 20 minutes-ish. When I use AI to do this, it took me 2 hours to come up with everything. And actually, I want to mention that in the table over there, what product that we, UT Health Houston here, we offer the most number of AI courses for credit. We have 5 of them. And so the core AI courses here. So that's the scale we're talking about. And if you look a little bit further, so it took thousands of years for the agricultural revolution to take shape, to have impact globally in the world economy. And for the industrial revolution, it took centuries, 200 years-ish. Now for the AI revolution, it only takes decades, 10-year, 20-year time frame. We already see the impact. So that's where we are. Now let's get back to research, which is highly relevant to our awardee today. This is part of the AI strategic planning we have been doing, and we put all the data from NIH Reporter, all the grants that are related to AI from NIH. I want you to focus on the one at the bottom left. They are from the different institutes. The biggest one is National Institute of Aging. The second one is National Institute of Neurological Disorder and Stroke. The third one is National Library of Medicine, which is one of the smallest institutes of NIH, but is the third largest grant source for our school. And you will hear more about our awardee later. She played a major role behind this. She spent all money here this way. All right, so most recently, our UT Health Houston received a large grant, $27 million from the National Institute of Aging to establish a data collating center for Alzheimer's and related dementia with 10 institutions across the nation. And the 3 PIs here at UT Houston are GQ Zhang, Contact PI, along with Hong Fan Liu and Li Chongchui, the MPIs. The 2 ladies are from our school. GQ was based in neurology with a joint appointment with our school and our school public health. And now, even more exciting, just this Tuesday, okay, Texans literally voted to fund a $3 billion project for dementia research for Texas only. And it's going to be for 10 years, $300 million a year. It's for research only. So, and we are ready to move to the next step. Okay, now onward, let's move to the Glaser Society and today's honoree who helped make all of this happen. Before I hand it over to John, let me just give you a brief history about this Glaser Society. In 2016, the Zhang P. Glaser Health Informatics Society was initiated by the McWilliams School of Biomedical Informatics in recognition of expertise and leadership of Zhang P. Glaser, PhD, who is a universally recognized thought leader in the field of health informatics. The Zhang P. Glaser Health Informatics Society was created to acknowledge innovators in the field of health informatics and provide education, collaboration, and networking opportunities for the broad community of health informatics professionals, clinicians, and students. In 2016, Ivo Larson, who is here with us, notable health information technology entrepreneur, was the first recipient of Zhang P. Glaser Award. David Bates, Harvard internationally recognized patient safety expert, who is also with us today, received the award in 2017. And Steve Lieber, former president and CEO of HAMS, is also here with us. And he received the award in 2018, in 2017, 2018. And then we passed 2 years for the pandemic, and then the next award went to Graham Grave, who was the founder of HR7 Fire and Fire Project Director at HR7. And he accepted the award in 2019, and sorry, I missed up with the COVID. So that's before the COVID. And Clem McDonald, Chief Health Data Standards Officer of NIH National Library of Medicine, was given the 2022 Glaser Award after the pandemic. And Dr. Maureen Ball, a renowned expert in health informatics and education, a witness and creator of entire informatics. She is the living history of entire field over the past 50-some years. She knows everything, everybody. She was an awardee. In that year, she is also with us today. And Judy Faulkner, who did come here, if you want to ask why an Epic CEO want to come here, she did come here with her team, a crew, and come here to receive an award last year for her for the recognition of her founding of probably the most successful health IT company in history. And so now I will hand over to Zhang to honor our awardee today for this year.
You're clapping for him, not for me, which I presume is. So anyway, you've all wondered, and I thought I'd go ahead and tell you, what's the P stand for? It's Patrick. And so when you have a mother whose grandparents were actually Catholic refugees from Ireland back in the 1800s, you wind up with a Patrick as part of your middle name, even if you have the German Glaser. There you go. If you remember nothing else other than Patty's comments, you'll remember that as we go forward here. I have a couple of things. One is as Zhang mentioned, the intention of the award was to recognize innovators in the field of health informatics, and I am delighted today to be honoring a colleague, a good friend of mine who's known throughout the world for her incredible contributions to the advancement of informatics. And by way of background, all of the award winners, and she is no exception, have made significant contributions toward helping us apply digital technology to improve the health and health care of people throughout the world. Care that is of higher quality, is safer, more efficient because of her work. That being said, I'm going to go through quickly the sort of list, a little bit more elaboration on the list that Zhang mentioned before I fully introduce Patty Brennan. If we go working back in time, Judy Faulkner, as you know, and you can see with her name up there, set the high standard for digital technology support of both clinicians and patients for a better care experience. Marion Ball, our colleague who's sitting right here, has educated tens of thousands of health professionals and materially advanced the field of nursing informatics. Ivo Nelson, who I think looks like Grizzly Adams, who's two people down for them, is a legendary entrepreneur in the digital health field who has established an industry-leading consulting firm and also fostering multiple startups. Like Marion, Ivo has also been a leader in multiple associations, or industry associations. David Bates, a colleague of mine from Partners Healthcare and the Brigham, his research, clinical work, and publications have helped us understand the impact of digital technology on healthcare, providing lessons and guidance on its effective use. So it's been a pleasure over a long period of time to have worked with David. Steve Lieber, who was the president and CEO of HIMSS, the Healthcare Information and Management Systems Society, which is the preeminent association in this digital health field, was instrumental in growing the field through the conference and the educational activities and the advocacy activities of HIMSS. Graham Grieve, who is not here, created the FHIR standards, which and has been sort of opened up the door or made it a lot more tractable, frankly, to engage in interoperability and innovation. Clem McDonald, who is the Chief Health Data Standards Officer of the NLM, helped shape our field almost from its inception. So a number of us who go way back remember Clem as one of the early pioneers who truly created the first generation of electronic health records and has since then been a major contributor. And as you might expect, given that august lineup of talented, extraordinary leaders and contributors to the field, this year's awardee is no exception to that. So Patricia Flatley Brennan, you can call her Patty, that's what I do, who is a nurse but also has a PhD, has built a visionary career at the intersection of nursing and engineering, making her one of the most influential people in healthcare informatics today. So here, Patty's, let's see, make sure I got this right. As National Program Director of Project Health Design, this is a Robert Wood Johnson initiative, Dr. Brennan spearheaded the design of next-generation personal health records aimed at integrating patients' day-to-day healthcare observations into clinical care. Through these and other pioneering projects, she has empowered patients to actively participate in their healthcare at a way and a level that was different. Materially different than it's been before, and her innovations have had a profound influence on how modern health IT tools are designed to manage chronic disease at home and in other settings other than the office or the hospital. In 2016, Dr. Brennan made history as the first nurse and the first industrial engineer appointed to the National Library of Medicine, or NLM as you know it, which is the world's largest biomedical library. She served as NLM director from 2016 to 2023, during which time she transformed the institution into a global hub for biomedical data science, strengthening NLM's role as a worldwide leader in biomedical informatics and expanding its digital infrastructure to make health information more accessible and actionable for researchers, clinicians, and the public. She co-led the development of Digital NIH, the NIH's first long-range strategic plan for data science and computing platforms, and helped shape U.S. health data policy by advising on federal initiatives in areas such as artificial intelligence. She served on the White House National Science and Technology Council's Machine Learning AI subcommittee. And just you think she was done, I'm not, because there's more to come on describing her. She also championed the inclusion of patient-generated health data in electronic health records, an effort that contributed to federal requirements, ensuring that patients' information and observations are incorporated into electronic health records. Her extraordinary contributions, surprise, surprise, have earned widespread recognition. She is a member of the National Academy of Medicine and a fellow of the American Academy of Nursing and the American College of Medical Informatics. Among many honors, she received the 2018 Morris F. Collin Award of Excellence. This is the highest award that is given by the American Medical Informatics Association. And more recently, I'm sure we'll perhaps talk about this, Patty was the recipient of the first Patricia Flatley Brennan Award for Informatics Team Science. So terrific. Now, in view of her stunning and long list. No, I'm serious, Patty. I know you're blushing now, but there'll be more of that coming. I think actually a remarkable career and a remarkable impact. And it's not only this list of she did this and she did that, et cetera. But I think, and we were chatting about this earlier, the fact is that she is a role model for large numbers of people, and I think particularly for women who want to climb the ladder, and that's extraordinarily important. It's what I call a force multiplier, where your leadership is multiplied because you made others better leaders in lots and lots of ways, in ways you'll never understand or never be able to fully account, but exceptionally important. So anyway, because of all this, it is an opportunity delighted to honor a extraordinary colleague and a good friend with the John P. Glaser, remember P stands for Patrick, Health Informatics Innovator Award. Indeed, she is the champion of informatics and its potential to help providers and patients of the highest order. So, Ms. Patty, if you would come on up here, we have something to give you. There you go.
Oh, wow.
And it's... Terrific. Don't go anywhere. I mean, we can put it back here. We will mail it to you, and we don't want you stopped in security because it looks like you got a weapon here. Anyway, as you just did, let's congratulate Patty one more time. One more time for doing that. There are several individuals who were unable to be with us today, but nonetheless wanted to express their congratulations and thoughts, et cetera. And I believe we have a video that will be showing a number of your colleagues. So you and I can sit down. You'll be able to see it on the monitor there. But so why don't we go off and do that?
The words I'd use to describe Patty: dynamic,
engaging.
She's tenacious,
insightful,
creative.
She's pretty awesome. Well, I'm happy to be here today to acknowledge my younger sister and to do it on behalf of her very large family of 9 siblings, and to really let her know that, first of all, myself, and then on behalf of all of our brothers and sisters, we're so proud. And Patty's been an innovator, not just in her academic and her tech world and in her clinical related interests and in her federal government and academic appointments, but she's been an innovator in our family. And I think sort of what she's brought to her work, which is a mix of her great clinical training, her deep empathy for people, and her real desire over her lifespan to see health systems improvement, and then finding this space within the health informatics arena in particular, where she has made an amazing mark. As an academic myself, but without all those wonderful statuses that she has had, I've taught my sisters writing. So I have a personal appreciation of her, both as a sister and kind of as a colleague in the larger healthcare and public health arena.
Congratulations, Patty, on joining the ranks of many of the top thinkers and innovators in our field who've been given this award in John's name. I can think of no one more deserving of this award than you. You and John share many of the same attributes, as you know. Like John, you combine visionary leadership that really bridges technology and care, as well as a deep commitment to human-centered innovation and an unwavering belief that data and empathy together can transform the health of individuals and communities. I witnessed you demonstrating these synergistic skills as a champion for personal health records back when we were doing the Robert Wood Johnson Foundation's Project Health Design Initiative. I still love retelling your classic smart plate story. For those of you who haven't heard it, Patty would ask, how would you want a plate that can tell you everything about the food that's on it? A few hesitant hands would rise. Then she'd add, what if you had a child with a peanut allergy? And instantly the room looked like a scene from a game show. Your superpower is your understanding of how care can be transformed, to connect with an audience, and to share stories that spark curiosity. It's your superpower as a researcher, it was your superpower in the nursing space, and it certainly is your superpower as a leader. Like John, you use storytelling to bring innovation to life. There are countless examples. Just ask anyone in Madison or at the NIH.
Congratulations, Patty. Your demonstration of excellence in discovery, collaboration and networking for and in the health informatics community is outstanding and of great inspiration. I came to the University of Wisconsin and your health systems lab as a Fulbright Fellow and visiting researcher back in the days. You provided a rich and nurturing research environment and opportunity to come together, also coined in Fulbright's people-to-people diplomacy. International exchanges, spending time together to collaborate, listen and learn for appreciation and understanding of different perspectives are still so important. The opportunity to explore what people do with health information at home and participate in the Health at Home study that you led continues to drive my curiosity and inspire research. Everyday health activities and digital tools fit for purpose is a key focus of my research activities here in Norway, in Europe, as well as public-private partnerships with global reach. Health data coupled with health information that are trusted, understandable, meaningful and actionable is necessary conditions for innovative digital services that are fit for sustainable care. Thank you for inspiration, for friendship, for guidance and for setting direction that has paved the way for innovation.
Having known Patty as both friend and colleague for over 15 years, I'm delighted to provide a tribute congratulating her on being named the 2025 John Glaser Health Informatics Award recipient. As friends, we have snorkeled the Great Barrier Reef, soaked in New Zealand's hot springs, watched fabulous sunsets in Tahiti, hosted a pajama party in Los Angeles, and drank caipirinhas in Rio. As colleagues, we were on opposite ends of the research to practice continuum. Patty spending much of her life in academic exploration, and I spending time in health IT operations in a practice setting. We often discussed how to move research into practice faster. And we always yet came together on two things: the key role of nurses who come to know their patients in a unique way, and the key role of the patients themselves in managing their own health and wellness. As NLM director, Patty continued both of these focuses. Patty's a fantastic communicator. She is one of the best presenters I have ever seen and has influenced so many with her insightful lectures and presentations. She also is a fabulous writer. In addition to her publications, I found following her NLM work and reading her musings from the mezzanines very insightful.
It's a joy to celebrate Patty Brennan as the recipient of the John P. Glaser Health Informatics Innovator Award. Patty's hallmark has always been interdisciplinary science, bringing together people with deep expertise in the necessary disciplines to solve problems that demand multiple scientific and engineering perspectives. She reminds us that while a team is necessary, it's not sufficient. True innovation and rigor emerge when each member brings deep expertise and a commitment to understanding and applying the theory of one another's disciplines. Patty has modeled that standard throughout her career, showing us that the magic of informatics lies at the intersections, where disciplines meet, learn from each other, and together make impossible possible.
Patty has consistently brought to her work, her practice, a deep sense of how her faith and her commitment to community is a part of doing the work that she does. And even now in retirement, she's pretty active. And she's innovating in a whole range of other spheres that continue to surprise us, which include painting. So I think she got the innovator gene in the family, and that she's used it for great goodwill in her, not just in the academic arena, but truly in the system change areas. I bring greetings from our whole family.
Congratulations, Patty, on this well-deserved honor.
Congratulations, Patty.
I congratulate you with the 2025 John P. Glaser Health Innovator Award.
So let me wrap this up by simply saying one thing. You go, girl. Congratulations.
So you clearly have a fan club. I hope you're aware. So I think, Patty, we'll turn these things on because we're now going to go into it. So I guess, sure, oh, there we go. I used to be a CIO, as you can tell by my handling of complex technology, et cetera. No, I think if you ever want to formalize it with T-shirts, bumper stickers, the whole thing, we're here for you, okay? I think you got to, there's a real opportunity to spread the word here. So what we're going to do is you can see sort of a fireside chat type of format.
Wait, you have to let me speak for just a minute.
Okay, go ahead.
Excuse me, but thank you to the developers. Thank you to the entire department. What an amazing treat that was for me to watch. I just want you to know the ability to have touched technology and people throughout my career is only possible because of the people that have walked that way with me. So thank you so much. Okay, John, back to you.
I forgot where I was. No, but we're going to have a little bit of fireside chat. I have a series of in-depth probing questions here that we'll ask Patty, and she will probably ask me a couple along the way. And, broadly looking at the field and, where it's heading, et cetera. And we'll reserve some time towards the end of our conversation for you all to take advantage of the fact that she's sitting up here and you can ask her questions and things along those lines. So anyway, Patty, looking forward to this discussion and conversation.
Same here.
All right. Well, let me begin by, I think one of the, broader understandings is that, I'm just going to ask you to reflect on how the larger healthcare environment shapes the work that we do in informatics, and vice versa. How does informatics shape the larger healthcare environment? Sort of a broad sort of understanding of the interplay between them.
Well, I think if you take modern healthcare, arguably dated from around the middle of the last century, we've been in a tag team race. So healthcare advances, information technology and informatics advances, and we've been a little bit ahead and a little bit behind each other all the way through. What was critical to me as I started in my journey in the 70s was the realization that technologies prepared for professionals were essential but not sufficient to make sure we had health for all. So early on in my career, I began to look for ways to bring the patient into the center of the health information technology environment, only to realize that while there was a lot of interest in healthcare, there was not the full readiness that we needed to have patient-centered care and patients contributing information. What if the patients weren't honest or accurate with their information? So throughout the process of technology-driven healthcare shaped technology, what I've realized is that the dialogue is incredibly important. Making sure that terms make sense, making sure that the tools we build as informatics professionals actually match and perhaps push forward what's happening in the health arena. Now, in the early first part of this century, we're now facing several new challenges. How will we provide health for all anywhere and everywhere? How will we make sure that information captured once gets effectively and safely used many times? How will we leverage what is happening through our colleagues in computer science and mathematics with these advanced analytic tools to make sure they actually serve the goals of healthcare? This requires yet another transition into conversation and dialogue to ensure that the goals and the perspectives we hold in healthcare are aligned with and accelerated by the technologies that are advancing. I have two concerns, and I hope you can solve some of these concerns. The first one is the information technology tools we provide most clinicians have only a slice of that clinician's daily need captured in those tools. And we have clinicians who need to know what happened to this patient 2 weeks ago. What can we forecast into the future? Who else is taking care of this person? And yet our technology tools are a one-to-one interface with a single clinician at a time. That's not going to be enough for the future. The second piece that we need to think about is that as technology advances, some of our clinical colleagues are worried for reasons, frankly, that I don't completely understand. But what I recognize is that the world is changing, and our ability to envision healthcare completely conceptualized in the mind of a clinician, controlled by a single discipline, no longer exists. We have patient-generated and patient-directed care. We have opportunities to intervene with patients when clinicians are nowhere in sight. So technologies that can advance the care and the health of all might be more disruptive to our workforce than we had anticipated, and we need to bring them along.
It's great. I mean, great answer, as always. A couple of thoughts. I do think, in one way, when you say the environment wants X, we want to engage our patients in a more concerted fashion. We want to be able to move to value-based care, which I'm sure we'll get to it, et cetera. And then people say, well, is there technology that can help us do that? And so they go search for it. And the market response is there's a market. If I created a Gorball 5000 that would do that, there's a response. So there's a market-driven series of technology innovations. Every now and then, I actually think every 10 years, a technology arrives that changes the world. So it goes back to the mainframe, the mini, and then the internet in the 90s, and then the iPhone debuted in 2007. And people say, holy smokes, is there something I could do with this that I hadn't considered doing before? And say, yes, you could create Uber, which I hadn't even thought about having this sort of network device on the person that knew where you were. So there's this bi-directional sort of one shaping the other or enabling. I do think what happens to some of Patty's points here is that you don't often know exactly what you have unleashed in some of these things or the anxieties that you will create. You can only see so far in terms of impact, and then you put it in play, and all of a sudden there are sequelae here. There's downsides, there's sort of changes in power structures and things along those lines. I do think what a critical thing, and particularly for all of you who are in the process of getting aged, the way it will fundamentally work is there is respectful and mutual understanding dialogue between those who are creating this stuff and those who are using it, et cetera. And each is listening to the other and teaching the other and understands where they are coming from and their sort of value propositions, et cetera. And that's, when we start talking at them as if they were children, then you begin to lose them, or they start feeling like they're victims. Then you begin to lose them.
So I want to go push back a little bit also to think about what should be happening in pre-licensure education and across our entire K-12 educational system. We cannot keep adding stuff to the clinical curriculum, period, end of story. It's too dense. We need to refine and reshape what we're using in the clinical education process to help people know in the moment what they need to know. And this doesn't mean jamming more into their heads before they graduate. It means making them nimble users of technology that allows for engagement with knowledge at the point of care. Additionally, the kids from K-12 are a lot further along than most of us are. They can go faster. They know things. I watched a YouTube video the other day and I realized there's a whole community out there that has never once picked up the New York Times and doesn't even care that they haven't picked it up. So we have a different environment. We need to learn to leverage as educators, to leverage that curiosity coming with that 12th grader who's completed 12th grade, but is also a Python programmer, is also able to understand how to use Instagram, what we might do if we had in the moment malleable gloves to interact with the device with. There is knowledge coming at us in the pre-licensure period that we can capitalize on and bring practitioners into a future of technology that they can both envision and make good use of.
Do you think we know how to train people who sort of grew up with this stuff? So you got an issue of the educators are from a different generation and don't have the same instincts and the same facility, so to speak here.
Well, I think it's hubris to think that they should know what we know. Yeah. So when we start off an educational program, I think every paper I've read, you should also read. And by the way, you should also remember this. And don't forget that I wrote some of them 40 years ago. We have to reframe our teaching learning process. So, when, technology-based interventions, computer-aided instructions and such were coming out in the 80s, there was a question of what is the role of the teacher if we're going to have computers that can teach everything? Some people remembering the Jetsons from way past where Rosie just ingested all the knowledge. Now, the role of a teacher has never been more important, but it is not as a conveyor or purveyor of knowledge. It's an extractor and an integrator of knowledge. And the presumption that our trainees and our students and even our high schoolers come with a knowledge base that we should be building on rather than erasing and replicating, I think is going to take us farther.
And I think perhaps the one thing you can't train is things like political combat in an organization and how to survive. Those are experiential. You just have to get out there and mix it up, et cetera.
So this may or may not be the point that we're supposed to get to the politics part of the evening, but we have a situation for easily 45 years that politics has driven healthcare. Healthcare has become a political action. Healthcare options and funding results from many political choices. And we are woefully under training our trainees for how to understand how the political environment shapes care. And what we must remember is that we don't reframe our health information practices every 4 years because an administration changes. We have to have a guide for the future of what we as experts in the intersection of health and technology are moving towards, recognizing that sometimes we have to adjust our methods, but not our goals for political changes.
And I think that becomes part of the skilled navigator process, is to realize that, in fact, the fact is politics have always been part. And whether I'm old enough to remember when AIDS was sort of taboo to talk about in the national discourse. And that's just the way politically that moved at that point.
I try to remind students and trainees now who are terrified with what they see as capricious, either defunding or not funding certain lines of work. And I remind them back to the IVF, assisted reproduction in the 70s, and condoms for AIDS prevention in the 80s. There has always been something that does not fit into a federal vision of what we should be funding. And institutions who provide education and research training and research activities must remember that that doesn't mean that those concepts are irrelevant or go away. We need to find ways to preserve them as part of our knowledge base, even if they're not at the moment part of our funding opportunity.
I'd like you to comment as we explore the evolution of biomedical science and how biomedical informatics accelerates or doesn't the progress of that science.
When I think about biomedical science, I think writ large, from cells to persons to clinical practices. So we're talking about the full range of discovery necessary to comprehend and identify generalizable truths and effective solutions to complex problems. So our own field of biomedical informatics has really invested heavily in the clinical understanding and the awareness of an individual at the point of need in a care service, what kind of information flows need to be brought together, has done even way back into the 70s. I think of the integration of clinical record systems, laboratory systems, imaging systems into electronic health records, which seems sort of seamless now, but it wasn't from the beginning. In addition, though, informatics, the biomedical informatics community has offered things such as formalism, understanding how knowledge is organized by linking words and concepts and text together. And that has relevance broadly across the whole range of discovery of in biomedical sciences, not simply in clinical practice. So we do have challenges of organizing the genomic information and proteomic information that's coming out of our understanding of single cell phenomenon and the impact of different genes across species on the health of the public. Health informatics has some structures that could be more generalized. Now, part of what's happening, and I don't see it happening as much in the clinical arena as I did see it in the basic biomedical and genomic science, is that sometimes the technology becomes a partner in the discovery, not simply a facilitator of the discovery. And by that, what I mean is that when we saw a shift to high throughput sequencing for genome analysis, we saw a change in the way genomic data was deposited in public repositories. Initially, legions of graduate students would perfect a sequence before it was ever deposited into a repository. Now, with high throughput sequencing and the error checking and quality improvement, the repositories are becoming partners in the process of doing research. That is, sequences are proposed, run through a tester or run through a quality assurance. Errors are found, the information is sent back to the depositor. So this shift in when does a biomedical research experiment end has a lot of implications in terms of the technology we need and the communication about those technologies, the metadata that's provided to individuals. Rethinking the discovery process, accelerating it through the effective use of information technology supports actually began over 20 years ago with high throughput sequencing. But now we have questions about how will AI optimize clinical trials? How can we bring in estimations of patient performance by understanding small groups of data about individuals? The idea that biomedical research can benefit from directly discovery processes that are driven by technologies is slowly becoming accepted. And if you ask me, it needs to be accelerated more because the discoveries are needed faster than the discoverers can develop them.
I was going to ask you to sort of elaborate on that, sort of the impact of whether it's, clinical trial conducting that or the sort of real world evidence, induced post-market surveillance or detection of correlations, et cetera. I mean, what's your sense of where that's taking us and how potent will that be?
Well, I guess I go back to what my mom used to say, there's a time and a place. So we will never not need clinical trials. We recognize they're expensive to produce. They are very difficult to reproduce. And the clinical trials machinery is often purpose-built for a specific targeted organ or targeted study. Real-world data, on the other hand, is mucky and massive, but man, does it contain some interesting insights. So the idea of making use of the appropriate data collected under specific systems for a specific questions, I think will be where our future lies. I don't see us being able to ever possibly curate every piece of data that's an electronic health record and manually or even from a computational approach come to a structured representation of it. We will need new kinds of tools that help us to extract knowledge from messy data, from real world data. Will it ever replace predictive modeling? I don't think so. I may be a bit of a traditionalist here, but I think without the control that a clinical trial provides, we have a difficult time predicting the likelihood of the outcome from the intervention. Now, I will talk for just a moment about how difficult it is to do a good clinical trial. Embarrassingly, 1/3 of the clinical trials supported by the NIH are never reported in a paper, are never reported out to the public. Why is that? Insufficient samples, a failure of a hypothesis, and we have a publication bias that our positive hypothesis supports are much more likely to be supported than our unsupported hypotheses. Much more likely to be published. So we have to think about different ways to learn from clinical trials, not necessarily to stop doing them, but to make sure if we initiated a strategy strategy and we're unable to complete a sample, or if we did, in fact, have a result that didn't turn out as expected, we have to find ways to integrate that into a knowledge base. So I see here a real shift in a real opportunity in the publications arena to think about how these different pieces of information get brought together. I'm very much of a Bayesian, so I'm happy to think about how we can learn a new thing, maybe from a small piece of information, maybe from a larger piece, maybe from a negation. We have a little bit of hubris in the publication community. We've all laughed about the Journal of Irreproducible Results, and we all know the person who's tried for 15 different publications to get their paper, and they finally get into something, so it's off their desk and out the door. This strategy is not sustainable for science. Finding ways to help people know when to end research projects, get reports written and produced into the public hands is an important step. This requires a shift to some extent in our incentive strategies in academic areas where publication, the number of single word journal publications you've got somehow carries a different kind of a meaning. And we in science and society have to come to grips with the fact that incentive structures may pervert learning, and it's time to stop that.
Yeah, one comment, and particularly on the real world, when back at Partners, a colleague, a guy named John Brownstein, looked at data from the Brigham and the Mass General where the admit diagnosis to the emergency room was heart attack, confirmed as heart attack. And he ran it over a period of time from mid-1995 all the way to 2010, and you could see about 2000 it spiked up about 20%, stayed elevated for 4 years, and dropped down to baseline. Vioxx prescribing began, Vioxx removed from the market. And I remember showing this to the Partners board, and Jack Connors, who was the chairman, his reaction was, holy shit, which is exactly the right reaction, because you could have seen that within the first 6 months. The confidence interval was such there was something going down here. Now, it may not have been definitive to pull it from the market, but there's a canary in the mine phenomenon that would have pointed to something to pay attention to.
So we have a challenge in that clinical information was once perceived to be the sacred product of a clinical encounter, and that was it. Maybe I would tell you, or I would talk with the patient, or I'd send it on in the chart to the next, but that was it. And what electronic health records have enabled, which excites some, terrifies others, is that those data points generated in a very intimate moment of a care between a clinician and a patient have now become the fodder for research. Finding strategies to make effective use of that data, finding ways to help clinicians understand the importance of data captured once could be used many times, and helping patients to understand what are the privacy considerations of that information are all part of the sociology of health information technologies that I think we have great opportunities to take advantage of. I believe we need the kindergarten curriculum for health data that's as good as the one for infection control, because every kindergartner knows wash your hands after you go to the potty. No question, they all know it, but they don't know health data is an important resource that will not only help you, but the person next to you or someone down the street. So if we can begin to integrate health data into the fabric of everyday living, I think we'll make some progress.
Well, while you're on that vein, you've done, as we've mentioned in the describing of your phenomenal background, a lot of work on engaging patients using the tech. Where do you think we are today? I mean, and what needs to be done to sort of really take that to whatever that next level might be?
Kevin Johnson mentioned the Project Health Design Initiative, which happened around 2002, 2003 till around 2010. We had an investigator in that group who was interested in voice technologies. He was a natural language processing expert from Buffalo, and he was convinced that people would wake up in the morning and want a device, not a human, a disembodied voice to say, good morning, Patty. How are you feeling? It's 72 degrees outside. I thought, not a chance. And yet, how many Alexas are there in the world that are now doing that for us? My own mother at 96 years old gets the news from Alexa, listens to Perry Como from Alexa. So the idea that technologies emerging may have a health benefit, I think, is improving a lot. Are we ready for it? Where does it go? Do we understand the privacy issues? Not yet.
Yeah, although you look at the fastest growing cohort of Facebook and social media tools, it's 65 and older. It's sort of picking people up in dramatic ways, et cetera. Now, if you could change the landscape pull 4 or 5 levers to truly advance our ability to deliver care, perhaps digitally enabled care, what would you change? What would you, if you had godlike powers, how would you exercise? Above and beyond create your own fan club, how would you exercise?
Well, so John, this won't surprise you, but I'm not sure I would advance care as we know it today.
Oh, okay.
I might
Then
want
what might you do?
Yeah, I might want to have technologies that might modify the number and frequency and nature of a person's engagement with the healthcare system. So to look first of all at number, it's both too low and too high. People who can't be seen, people who are seen more often perhaps than they need to be seen because of other incentives, reimbursement structures, or patient fear, or clinician monitoring patterns, personal patterns. The kinds of encounters, the nature of encounters, we often think of, I have to be on your turf, in your place, wearing a little gown for a healthcare encounter to occur. But we know more and more that health is something people experience every day, and the choices they make every day play a huge role in their ability to prevent or manage complex disease. So finding a way to, if you will, elevate the everyday experience to health enabling activities for individuals, I think may alter the number of times individuals show up in the care facility. So that means bringing technologies into people's homes. That means bringing useful technologies from the home into the clinical encounter at the points that are needed. It means modifying the reimbursement structure so that clinicians who are not seeing the patients still have a way to charge for the time or get compensated for the time they're seeing a person. But I have a couple dream ideas of what I would really like that I think might be game changers, even if we can't fundamentally in the next 10 years change the nature of the healthcare delivery system. The one I want first and foremost is privacy management tools that really work for patients and for clinicians and for knowledge building. Right now, they're treated as 3 separate entities. They're cumbersome. They're hard to keep track of. They're often ignored. And we have a situation where information about a person is often used without that person's knowledge. So I'd like to move into some privacy management tools that are useful, tractable, and perhaps even understandable by everyone, including my mom. The second thing I'd like to see information technology do is to provide the same early warning to an individual that something's not right, that we know certain studies are showing happen, for example, when a nurse enters a patient's room more often than they have been. That change that indicates concern actually is predictive for health outcomes for that individual. Could I have something in the mirror of my bathroom at home that would say, your face looks kind of off today. Are you feeling all right? Could we track the slow progression of a stroke or maybe a person's oxygen level by using environmental monitoring that would alert the individual for the need to take individual action? The third thing that I want is something to make the experience of being in a care facility more meaningful. And I'm speaking really right now to the waiting room, which is a place that individuals spend a lot of their time and of necessity right now maybe have traveled a long distance, have to sit for a while. I am not in any way suggesting we put health information kiosks into waiting rooms. I've never liked that idea because health information is a complex and if sophisticated intervention needs a little more concentration than that. But are there ways that we could better use optimization or mathematical modeling to manage scheduling to make sure that people are scheduled at reasonable intervals, not at predetermined intervals? Are there ways that we could use technologies that would actually allow for pre-screening so a visit became 3 or 4 encounters, including brief telemedicine as well as an in-person visit? Are there ways we could do follow-up in a meaningful way that would ensure a person is not sent home from the hospital at 2 a.m. without their meds and still gets reminded the next day, time to take your medications? So I think the technologies need to be advanced to fit into some of the challenges we're finding in the processes of care right now.
Yeah. Well, a colleague of mine, and I'm curious to see what you think of this, thought that the way to do this was friction reduction.
Okay.
And he basically said, for example, he was a CMIO for a large health plan. And he said, we want men to get prostate exams or increase the rate at which so the basic idea is you could walk into any urgent center and say, I want a prostate exam, and that's all you needed to do, period. no paperwork, no proof of coverage, this, that, or the other. And so it just made it trivial to do in lots of ways. And it's like getting an appointment. It's just to reduce the friction of getting an appointment, or to know, to your point, you're being, your face color's off, et cetera, is it becomes increasingly less and less of a thing you have to do. It just becomes part of the fabric. And that still won't help necessarily the person who thinks they're immortal, the 18-year-old male who says, I'm going to live to be 107. But nonetheless, that was his whole thought. Is you don't try to motivate necessarily. It's just to make it so that it requires so little effort on your part that it's almost automatic. What do you think of that?
So I would describe that as reducing the activation energy.
Fair enough.
How much does it take for me to have to get this? And you've thought much more about the payer side of the equation than I have. And neither of us have thought very much about physician licensure. Mm-hmm. But we know that certain things can only be ordered by a physician.
Right.
Why? I don't know. Physicians who are here, maybe you can answer that for us. We know that payment systems use governors to make sure care is appropriately authorized. And yet there are reasons why activation towards care could be reduced. And I don't know that we would see the tsunami of inappropriate use after care. But it may be because we have a litigious underlying of our society still.
Well, and I think it's, those of you, a number of you may be health plans, it's a very conservative set of part of the industry, et cetera. And it's, it's worried about, in fact, the ESRD experience haunts them.
Yep. Is
that it seemed like a good idea and then took off to the races, and it's the sort of giant that ate New York as a result of this stuff. So they're worried about, and probably Ozempic and the GLP-1s we're in that same boat now, et cetera. It's just letting things get out of hand. And so their expense base and their customers, which are the employers, are going crazy on all this stuff here.
I'm thinking back to 1990, 95, when electronic mail was becoming a part of the clinician care process. Yeah. And there was a question, what will we do with this? And what are the proper things to say in electronic? And I wonder if those clinicians, and I'm thinking of Danny Sands in particular, and Beverly Kane, who was very active in producing guidelines for informatics, if they knew about chatbot answering to portal posed questions and what they would think of that.
Yeah.
I think that when you set up a structure where people are engaged in meaningful decisions about their care with appropriate guidance and interventions from clinicians, you do get good outcomes. Mm-hmm. That could be generalizable to most, but not all of the population.
Yeah. Well, I've certainly used ChatGPT to self-diagnose. And
good.
Yeah. And I'm still here. And I'm still here. No, it's actually quite remarkable. So there's certainly, what do you think of, the sort of prospects of AI? I mean, a lot of buzz, et cetera, and some is over the top, et cetera. But what's your sense of where that will take and how big of a deal it will be?
Oh, I think it's a huge deal.
Okay.
And I'm actually pretty pro AI. Not any AI. Of course, I want the Patty Brennan version of AI. But the possibility of cognitive assistance through the complexities of care by an individual, a person, is so enormous in the ability to reduce fear, reduce reluctance to get appropriately timed treatment, and to improve the health experience. So I think we have a great deal of opportunity to manage to work with the public. Now, we still have huge amounts of misinformation. You saw my family there, so you can imagine that we probably don't have all the same attitudes towards everything in our family. I have a sister-in-law who absolutely believes she got COVID from a COVID vaccine. Absolutely believes it. There's nothing I can do to change that. So I understand that simply providing tools is not going to solve everything for everyone. But as it takes us further in society, there will be uptake. Yeah. Now, about AI for clinicians, I believe that clinical care is becoming so complex that tools that help a clinician sort through priorities, have a good idea of the probabilistic outcomes of various approaches to treatment, and can assist with making those decisions will be helpful. But I do not believe for a minute that to say to the clinician, you have to validate this AI before you use it, it's going to work or be scalable. We need something different. We have to figure out how to manage this ambient listening approach to record keeping that doesn't put the clinician in the position of either glancing over it and saying, yes, that record looks fine, or spending additional time with the record. And that, to me, requires a better integration of human factors. What do we make records for? Why do we want them to be that way? And who is the validation source for this information?
Yeah. Well, I think it's fair enough. I mean, I have a colleague who says that the AI impact on the clinician will be that it will change from making the decision to checking the decision.
Yeah.
And so validating that which has been come up, and fair enough. I also think, in listening, we had a conversation a couple of months ago, I did anyway, with 3 CEOs of health systems. And so they were talking about AI, et cetera, and they're looking at the precipice called HR1, the big, beautiful bill, and its impact in 26 and 27, and saying we're kind of hosed now, but we are really going to be under the gun fiscally. And whether AI has got enough staff relief and just taking administrative processes in a very big way, taking out huge costs, and we'll see. And it may not be in the clinical side, it may be more on the administrative side that sort of impact is happening. Sorry.
But I think that requires a rethinking of the interdependencies and decision-making structure in the institution. So if, for example, AI systems that manage HVAC and manage materials flow and manage growth actually lead to efficiencies in the system, actually lead to a redistribution of where money gets spent, that has to be looked at in the context of what's happening on the clinical arena also. Right. So savings on one side may not actually lead to savings on the other side. And as we were speaking earlier today with some of the students, even if the practice saves money, if the person doesn't get a financial incentive from an intervention, that may not be beneficial. So I'm not suggesting we should not do that, but I am suggesting as we rethink governance in our care delivery systems, if there are benefits to be gleaned in automating processes or adding AI into systems, those benefits should be, and consequences should be examined across the system.
Yeah, there's people who sort of study. One of the things they notice there's when you get major technology innovations, there's first order effects, second order, and third order effects. First order is generally substitution. We used to do it this way, now we automate it, but it's the same thing. Moves faster and less expensive, et cetera. Now, having done that, you begin to see, well, holy smokes, there's a second order here, and the analog that was used is the automobile. It's first substitute for the horse. Having done that, you begin to see, I could do suburbs. There's no reason for you to live within walking distance or horse distance from your job. You could live miles and miles away. But you can't see the second order from the first order. You're still too busy. And it may lead us to sort of opening up opportunities to sort of change how we put it all together.
And it may lead us to rethink why we do what we do.
Yeah, fair enough.
One of the things that I know there's been pretty consistent disappointment in the last 18 months has been the demonstration that ambient listening does not save clinicians time. So that while it may save compositional time, there's still what someone referred to me the other day as pajama time, which is not a term I had. You recognize that term. I'd like to see this, rather than being disappointed that the ambient listening doesn't work like we wanted it to do, to take a look at what is it we want from clinical records, and what are we anticipating, and how do we think, who else do we think is using this? My fear is downstream, the AIs will be reading each other's records, and that will be what's driving care. And frankly, that worries me a little bit. I'm not sure that's a good idea.
Yeah. So a round of applause for Patty Brennan, and well done.